I was ready.
Then zoom in. Zoom it to near. Panelist. Assalamu alaikum. Aftab Khan.
Walaikum assalam wa rahmatullahi wa barakatuh. How are you, sir?
Thank you. Most welcome to today's session. Mojumdar sir নামটা চেঞ্জ করেন, মির জামাল স্যার এখানে আছে। মজুমদার স্যার আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম আসসালাম।
আপনার জন্য ওয়েট করছিলাম স্যার।
জামালের নামে ঢুকছে দেখি।
ওইটা চেঞ্জ করে দিচ্ছি স্যার। চেঞ্জ করে দিচ্ছি স্যার।
ওয়ালাইকুম আসসালাম। Nasrullah is in the Cathlab.
Sir, assalamu alaikum sir.
ওয়ালাইকুম আসসালাম।
বাইরে কেন আপনি আসলে বাইরে কেন দূরে কেন অফিস আরেকটা বন্ধ না
ওয়েলকাম ডক্টর আফতাব।
Sir, good evening, sir. Good afternoon.
Good evening.
এর আমার দেখায় না কেন
মির জামাল স্যারকে
মিজান দেখাও। মিজান ভাই আসসালামু আলাইকুম।
এই চলে আসছে। আমরা এখন শুরু করব স্যার।
এই তো দেখা যাচ্ছে একটা।
আসসালামু আলাইকুম স্যার, মজুমদার স্যার আসসালামু আলাইকুম।
জি, ওয়ালাইকুম আসসালাম।
আসসালামু আলাইকুম সবাইকে, মজুমদার স্যার, আফতাব খান, মির জামাল ভাই।
স্যার আমরা এখন শুরু করতে পারি। আমরা এখন ফেসবুক লাইভে যাচ্ছি স্যার।
হ্যাঁ যাও।
টু ফেসবুক লাইভ নাও। ওকে, মিউট প্লিজ। দেন
হ্যাঁ এই তো কয়েক মিনিট বসছি। ওর ইয়ে নাই কেন
সাউন্ড কোথায়?
Assalamu alaikum. Good afternoon. Welcome to today's scientific seminar webinar. Thank you all the participants and faculties. We are doing tremendous support IPDI Foundation last 2 years. Today we start a new journey in a hybrid session. We are really grateful our Mymensingh Medical College team. They are coming from here 200 miles from the Mymensingh at COVID era in our Cathlab, and also Dhaka Medical College students, and really grateful to Unit Hospital. They give chance to the IPDI Foundation to do this thing. Today our senior professor Fatima Begum here, our senior and Dr. Kaisar also in Cathlab, Dr. Shafiq ideally, and Dr. Professor Khalid Mohsin sir our here. And I see here Dr. Aftab Khan. He always our trusted friend IPDI Foundation from beginning, not only IPDI Foundation, Bangladesh Cardiac Society and BSCI also doing a tremendous job last couple of years. And our leader, Professor Abdul sir, Secretary General Bangladesh Cardiac Society, and also our director NICVD always supported us. With this support, we are going long way. And I really thanks to the participants last 2 years, they are joining with us all the times, day, night, and evening, every time we call, they're joining us. And also Beximco Pharmaceuticals, they are doing last 2 years, tremendous job with us. I'm requesting Professor Abdul, sir, please, few comments regarding to this session. Today's we do the live case demonstration for the Kaisar second. Dr. Abdul, sir, please, opening the session.
Assalamu alaikum and good afternoon to everyone. Today, we are going to be a hybrid session where our very beloved and very expert operator, interventional cardiologist, Dr. Kaisar Nasrullah Khan will demonstrate about the basics of a cardiac Cathlab, how to prepare a Cathlab, how to do the procedure, what to do and what not to do. His team will help us in ensuring that we have good demonstration. Good demonstration. I hope everyone will today learn from this. We are very lucky in this COVID era where Mamachi Medical College, Dhaka Medical College, which are COVID dedicated, we do not have a functional Cathlab at present because the whole area is COVID dedicated. Only the COVID patients are allowed there. And these students are very fortunate that today they can in person visit the Cathlab and the procedures that will be done there. And Kaisar will show them in person how to do these things properly. I am very much grateful to our faculties, Dr. Aftab Khan, Dr. Fatima Begum, Dr. Professor Chowdhury Ahmed, our leader, Prof. Abdul, our NICVD director, Professor Mir Jamaluddin. All of them are here. Their presence here gives us the moral boosting and also help the students in encouraging that all of our faculties are always with you. COVID, in this COVID era, will always flourish together. Thank you, everyone.
Thank you. Professor Abdullah Shovinder, sir, Secretary General Bangladesh Cardiology, please inaugurate this session. Professor Abdullah Shovinder, sir.
Very good afternoon. Indeed, it is my great honor and the privilege to be linked to this sort of program. And it is a novel arrangement with the hybrid program of doing the Cathlab demonstrations. And I don't have any adjectives to describe fully the initiative you have taken in this COVID era. And my thanks to the IPDI Foundation, its captains, Professor Abdul Chowdhury and Dr. Mohsin Ahmed, for organizing in the course of the days of different novel programs. And this is also a sort of novel program we have arranged. And my best wishes and my blessings with you to organizing all these sorts of programs. Thank you very much.
Thank you, sir. Professor Mir Jamaluddin, sir, Director of NICVD, sir. Professor Mir Jamaluddin, he also Secretary General of Bangladesh.
Thank you. Thank you, Professor Abdul Wadud Chowdhury and Dr. Mohsin for arranging such a nice and interesting as well as very important basic program for the postgraduate fellows. And we are very happy that you have arranged this as hybrid, meaning that those who are the postgraduate students, some of them are in the Cathlab, and with the expert like Dr. Kaisar Nasrullah Khan, they will be very much benefited by knowing the basics of coronary angiogram or basics of Cathlab and Cathlab procedures. So it's a novel idea, as well as I must have to congratulate IPDI as well as our Professor Wadud and Dr. Mohsin for arranging this program. Wish you good success in this subject. Thank you. Thank you.
স্যার আপনার থেকে একটু কথা নিয়ে নিচ্ছি নেক্সট মান্থে স্যার আপনি একটু সময় দিবেন ডিজিটাল রেডিয়াল এবং স্যার আপনি যদি সময় দেন আমরা আইপিডিআই রিয়েলি গেট টু ইউ স্যার
ওকে নো প্রবলেম থ্যাংক ইউ
আমরা কিছু ছাড়বো না আপনার প্রোগ্রাম চাই
না থ্যাংক ইউ
Thank you. I am requesting Dr. Aftab Khan. Please, a few words, kind words to our fellows and faculties.
Yeah, I think this is going to be the new norm now, at least for another 6 months to a year. I believe this hybrid conference is what is going to be the future. And I think I would congratulate IPDI as well as Dr. Abdul, Wadud Chowdhury and Dr. Mohsin Ahmed for making sure that the fellows are not left behind in this COVID era. So there is social distancing, but there is no distancing in terms of learning. I think that's important that they don't lose out another year in this pandemic. So congratulations for this endeavor. And I do hope that the fellows do benefit from this experience that they have from this vastly sort of experienced faculty that they have on this conference here.
Thank you. Our today's senior consultant, Dr. Fatima Begum, on behalf of United Hospital, please 3 words. And then we go to the Cathlabs.
Good afternoon, everyone. And I welcome you all on behalf of United Hospital. I am taking the chance to thank the IPDI organizer to select us for the hybrid program. I think all the fellows and all participants will get benefited from this discussion, and we'll do it group by group and the different institute, and it will help us to develop our the professional skill and to enrich our knowledge. And thank you everyone they are participating in this session. And I think Kaisar Nasrullah presenting the case very successfully, and he is the dynamic operator and the dynamic cardiologist in Bangladesh. Thank you everyone for coming here to enjoy the session.
Now mic goes to Dr. Kaisar Nasrullah Khan. Dr. Kaisar Nasrullah, please start your session. Now his ball is in your court. Dr. Kaisar Nasrullah Khan. Please mute yourself. Cathlab is unmuted. Dr.
Please
Motiur,
unmute. Kaisar, we cannot hear you.
Dr. Shaun and his team, please. Okay. Dr. Kaisar,
Can you hear me?
Yes, now.
Now we can hear you.
Okay. Assalamu alaikum and good afternoon to all. I'm really honored to present a simple case in IPDI banner. I would like to thank both IPDI and United Hospital management to arranging such a wonderful conference so that we can share our knowledge and teach our next generation who will definitely succeed more than us, inshallah. I would like to also thank Beximco for sponsoring this program. And we are going to start this program, but I will try to follow strictly the learning objective of the IPDI. So IPDI in their poster have given 4 objectives for this program. I will take them one by one. So at first, I would like to introduce my team. Dr. Tanbir, my specialist. Then there are 4 or 5 fellows from Mymensingh Medical College, and my sister Lokhi, and my intensivist Dr. Rashad, and also my other sisters and Cathlab technician Dr. Mr. Anwar and others there. And now I will hand over the mic to Dr. Motiur Rahman, who are our specialist cardiologist, who will pick up 1, 2, 3, 4 learning objective of the IPDI for this program. Let's start. Motiur, over to you. No.
Unmute.
Unmute.
Motiur cannot hear you.
Motiur,
Shaun,
unmute.
Shaun, please unmute. Motiur, please unmute yourself.
Am I audible now, sir?
Yes, audible. You large screen. You start, please start.
Motiur, start, please.
1 second, please, sir.
Motiur, everything is fine. You please start. talking.
Monsieur cannot hear from you.
Sir, excuse me.
Yes, start. Everything
Am
is
I
fine.
audible,
Yes, start.
sir?
Yes.
Thank you, sir. Welcome to IPDI live demonstration from Cathlab United Hospital. Today, we are very glad to have Chairperson Dr. Professor Abdul Wadud Chowdhury sir and Mohsin Ahmed sir as a secretary and moderator of today's session. And we are glad to have uh, presence of Dr. Aftab Khan, Senior Interventional Cardiologist and Director Electrophysiology Services, Apollo Hospital, uh, Kolkata. And we have lots of renowned and eminent cardiologists from home and abroad. And uh, today, live case demonstration is conducted by our dynamic and eminent mentor, Dr. Kaisar Nasrullah Khan, Senior Consultant, United Hospital, Dhaka. Today's objectives learns from the leaders. IPDA has made a platform for beginners. Those are intended to enhance their knowledge and skill in the field of interventional cardiology. We are very happy to present with IPDI. Today's four objectives and focus discussion. Uh, First is preparation of Cathlab before procedure, coronary angiogram tips and tricks of successful femoral puncture, decision making for intervention, views and images, interpretation, PCI. Start with simple case confidently. Let's start one by one. First, preparation of Cathlab before procedure. Before procedure, we have to prepare the patient, check consent for CAG or PCI or pacemaker, checks vitals like pulse, blood pressure, oxygen saturation, etc. Lab reports like hemoglobin, uh, creatinine, and platelet others. ECG, echocardiography, and imaging. Venous access, urinary catheter, and normal saline in case of CKD patient. And lastly, COVID test must have to done. Kaise sir?
So you can see our cath lab, and you can see there is some in the cath lab. There is our this is cath lab trolley, which is prepared by our cath lab staff nurse, and also you can see behind there are some or emergency medication there that like atropine, dopamine, dobutamine if there is a bradycardia or hypotension. And on the left side, you can see a red covered, which is our crash trolley. And you can see also the defib machine here. Can you show the defib machine? Yeah. So in the cath lab, you have to prepare for the normal things in the with the cath lab scrap nurse, and also the emergency things like emergency medications, crash trolley, defib machines, and also ventilator. Huh. So that's it. Next.
Thank you, sir, for nice demonstration. This is the cath lab. Cath lab team is cath lab is operated by a cath lab team, which includes an operator, assistant, intensivist, technician, nurse, patient care, and cleaner. So first, every member of team should wear a lead apron. This is the pre and post procedure patient preparation area where patient before going to cath lab has to assess, and after procedure patient also keep for monitoring and post procedure assessment. This is the cath lab having cath lab machine and monitors.
presentation to monitor it. Yes, whole screen. Whole screen.
Sorry.
Whole screen. Okay.
So this is the crash trolley, already nicely mentioned by our sir, and the photogram showing ventilator on the back, an infusion pump, defibrillator, electrocoronary machine,
Quick,
which is essential in case of PPM implantation, and this is the emergency medicine which may be essential during any procedure in cath lab. This is the radiation protective shield has to use in case of any procedure. ACT machine, which is essential to see the uh, see the ACT, as well as portable EQ machine, which may be essential to see the pericardial effusion in case of emergency. This is the CAG trolley, having some instrument which is essential for coronary angiography, and this is the pre-TCA trolley. You can see. Kaisar Nasrullah Khan sir.
You go to next. Just continue.
So coronary angiography tips and tricks of successful femoral puncture, which will be discussed by the Kaisar Nasrullah Khan sir. And today our patient, resume of history, 55 years old gentleman, diabetic and CKD stage 1, having history of STMI inferior 3 weeks back and thrombolysis in another hospital. On admission, he was hemodynamically stable and no history of chest pain or shortness of breath. ECG showing there is a Q wave in 2-3 AVF and also T inversion in V4 to V6 and presence of R wave in inferior lead. Echocardiography showing there is mid infralateral wall is hypokinetic and good RV systolic function with ejection fraction is 50%. That is MR grade 1. Coronary angiography revealed left main was free of disease. L6 had 30 to 40% lesion in proximal part, but principal OM had 90% lesion followed by total occlusion, which having retrofilled from left system. And LAD is type 3 vessel having around 50 to 60% lesion at the bifurcation of diagonal 1 and around 30 to 40% lesion in distal mid segment. Diagonal has a big vessel having around 70% lesion in its proximal part. RCA has 80 to 90% lesion in proximal part and around 70% lesion in mid part. So, Kaisar Nasrullah Khan sir.
We have shown the angiogram fully, and now in this banner we have got 2 points. One is talking about the angiogram, and second showing the femoral puncture. So I will do the femoral puncture first because I have to give heparin. Then we'll talk about the angiogram. So can I have the camera with me?
Camera focus.
So first we have to palpate the femoral artery.
ক্যামেরাটাকে ক্লোজ করো, সাউন্ড
ক্লোজ করেন,
আর
হাত দেখা যাচ্ছে।
লাইটটা অফ করে দেন, ওই লাইটটা কাইসাবের উপরে হাতে লাইটটা অফ করে দেন।
এটা অফ করে দাও।
ওকে গুড, আর লাগবে না। ওকে ঠিক আছে।
আচ্ছা
না অন করেন।
এটা অফ করুন।
ঠিক আছে।
So I am giving the lignocaine. One thing is very important for the fellows. We have to properly anesthetize the groin. If groin is not anesthetized properly, then
সাউন্ড ক্যামেরাটাকে অ্যাডজাস্ট করো, লাইটটাকে ফোকাস করো।
লাইটটা ফোকাস করছে।
এখানে লাইটটাকে
then the patient will feel pain.
Okay, good.
And then the puncture will be very difficult.
একটু বাড়াও লাইট। ওকে ঠিক আছে, ফাইন।
So I will try to do an anterior puncture. As IPDI has told me to do a femoral artery route, so I'm doing it femoral artery. Usually we do in radial route nowadays, excepting some CTO cases or emergency cases. So, but I think for all fellows, we should know how to do femoral puncture because we are not used to now, because radial route is now frequently done in all centers. But sometimes you need to do femoral puncture when you are doing CTO or you need a big excess, like for impeller, though it's not available yet in our country, and like doing rota. So 7 French, 8 French sheet are easily being introduced in the femoral route, but it's difficult to use in radial route. So after filling the femoral artery, I will try to do the anterior part.
Cathlab দেখা যাচ্ছে না, আপনার কোনো কিছু দেখা যাচ্ছে না।
Cathlab দেখাচ্ছে না।
না, দেখা যাচ্ছে, এটা দেখা যাচ্ছে, ভেরি নাইস দেখা যাচ্ছে।
দেখা যাচ্ছে না, আমাদের এটা দেখা যাচ্ছে না, জুমে দেখা যাচ্ছে না।
You proceed, আমাদের এখানে দেখা যাচ্ছে, ওখানে মধ্যে আমরা টেকনিক্যাল দেখছি, আপনি কাজ করুন।
I think Professor Kaisar, what the concern was that if you could have a fluoroscopy of the groin whilst you're doing it, it will become easier for the fellows to understand the landmarks, and they could probably see where you're intending to puncture. I think that is what would be probably a little more easier for us.
Can you connect to the fluoro?
Right, exactly.
Connect to the fluoro.
Yeah, right, exactly.
Dr. Kaisar, you can tell about the anatomical landmark.
You see the fluoro?
Like anterior iliac spine and pubic tubercle.
Can you bring the fluoro?
Actually, it is easier to palpate the femoral artery, and if you can show here the camera, you can do just 1 or 2 finger below the inguinal crease. So,
Tanbir, do you hear me? Tanbir, তুমি ফ্লুতে চাপ দাও, হাতটা দেখাও, ফ্লুরোস্কোপি
can you see the fluoro now?
ফ্লুরো দেখাও, monitor should be in the fluoro.
Yes.
Okay, good.
দেখান।
Nice, thank you guys, bhai.
Good.
Just location is good, very good. Okay.
হ্যাঁ, আমাকে ফ্লুরো দেখান আর এখানে একটা ছোট হাত দেখান। আচ্ছা, now what I've been trying to tell our fellows, first feel the pulse properly in your under your index finger or middle finger, then take the needle and make it like 45 to 60 degree perpendicular to the leg.
Can you show the camera?
So you can see I've done the anterior puncture. Camera দেখাচ্ছেন?
Excellent. More than 100 viewers. You puncture anterior wall is nicely.
So
Excellent.
I just the anterior puncture, because if you wall
Don't worry about the fellows, don't worry the blood loss.
Yes.
It takes only 10 ml dye. So sometimes fellows are nervous, they seeing the blood, but they were nervous.
Sorry. So just 1 or 2 finger below the inguinal crease, filling the femoral artery, I just puncture anteriorly. You can see the flow of blood, gush of blood, and then I didn't puncture the posterior wall because there could be sometimes retroperitoneal hematoma if you puncture posteriorly, but usually does not occur. So then I'm trying to take the, you can see the my wire in the monitor. Can you see it?
Fluoro.
Fluoro, please.
Fluoro. এটা দেখান।
Yes.
হ্যাঁ, এটা লাগবে না, এটা একটু পরে। ফ্লোর দেখতেছেন আপনারা? হ্যাঁ?
You see the landmark, excellent landmark. 1/3 of the
you can
head
see
and 2/3 is the
now it's gone to aorta. No,
1/3 you see.
So
and
so it's in the aorta now.
Dr. Kaisar, can I just
again please in the hand?
If your needle is still there,
I'm taking the introducer out, the needle out, then putting the 7 French sheet. So this is my 7 French sheet. I'm just screwing, just gently screw. Sometimes some people do a small nick by this scalpel, but I don't do it because I try to do it by screwing. But if necessary, you can also give a nick. Then it's done. So taking the wire and the dilator out. So I'm done with femoral puncture. Now I will give heparin because it takes some time to 4 to 5 minutes to reach the desired ACT. And remember, very important thing, before any procedure, you must see the ACT. Sometimes heparin does not work, and if you put a stent, there will be acute stent thrombosis. And it takes 3 to 4 minutes time. So
How much,
heparin?
Sir, how much heparin you give to the patient?
Usually
how
7
much?
to 8,000. 7 to
You are
8,000.
doing angioplasty, that's why.
Angioplasty.
During angiogram, how much?
2 to 2.5.
Okay.
Dr. Kaisar, would you elaborate a bit about your choice of sheath, like the hydrophilic sheath or the long sheath, while you are passing the wire into the femoral artery?
Yeah, of course, Khaled bhai. It's a very important thing. I'm not giving a bite there. You can see, and it's very important to give a bite in femoral root, because if patient become unstable, sheath might come out. So I'm giving a bite, and now I am done. My sheath is in, my access is done, and also my femoral heparin is given. So by 2 to 3 minutes after, I will do an ACT, and if it is above 300, I will start the case. In the meantime, we'll discuss other things as the IPDI objectives. Now, answering the Khaled bhai question, usually this is short femoral sheath, but if there's a tortuous aorta or there's calcified aorta, then support is difficult to take the guiding catheter. Then we use a stiff wire like N+ wire and take a long sheet. And long sheet are two types. One is medium long sheet, one is long sheet. Long sheet goes up to, subclavian artery, near subclavian artery. Our middle long sheet goes up to like renal artery. Then it will be easier to give support the guide catheter. So there are three types of sheet. Normal sheet, this is, which is a short sheet. One is middle sheet, and then there's a really long sheet.
Okay, Dr. Kaisar.
Kaisar,
yes.
You in 7 French sheet, usually you introduce by screwing, nothing else. You did not cut the skin.
No,
it depends. But it depends upon that. What kind of the sheet are you using? If it is Terimo sheet, it is beveled, you can put it like that. But if it is cordage sheet, sometimes it is very difficult. So you have to be careful about that. Number two, if you are using the reuse sheet, if you're using the reuse sheet, then I think so it is better to give a small cut. Otherwise, if you are using the new sheet and Terimo sheet, you can do it. But if it is an old sheet, there is the tip is not so much strength and so much what is that? Smooth like and so it is maybe difficult. So it depends upon the sheet. Because 7 French sheet sometimes is very tough, and sometimes it may kink or it may be problems.
Yeah, absolutely, sir. I totally agree with you. Especially in government hospital, we use reuse sheet, like Mohsin Medical College doctors are here, and some Dhaka Medical College. So at that time, we can give a nick with the scalpel, which I've showed the scalpel, and we can take the sheet very smoothly then.
Dr. Kaisar, just a small question. You just talked about the dose of heparin. Would that dose be altered if the patient has received a GP2B3 inhibitor, or if the patient has received, say, a low molecular heparin before you've taken a patient into the procedure lab? This is again a question from probably the question that many juniors would have.
Thank you, Dr. Aftab Khan. I really appreciate your question, and we are really honored to have such a renowned interventional cardiologist from our neighboring country here. Yes, if there is any blood thinner before, in whichever form, it could be glycoprotein 2B3 inhibitor, heparin, or 1080 place, we usually give lower quantity of heparin, like 5,000, and then see the ACT. And my target of ACT for any procedure is 300. 300, that's my cutoff value. And I don't see ACT again because I give this charge to my sister. She sees it every 30 minutes. And whenever this is below 300, he gives 1 or 2,000 heparin accordingly.
Right. So I think
it's her job, not my job.
I
have a question here, Dr. Kaisar. You said you will give the heparin first, wait for 3-4 minutes, see what the ACT is, and then start the procedure. I personally, I don't know how many interventionists do that, but I usually don't wait for the ACT. I usually introduce the guide. Sometimes, it takes long to, cannulate. Sometimes, it's difficult. Cannulation of the left main or the right takes time, but that's my personal practice. But I don't wait for the ACT to be 300 and then start the procedure. What do my other colleagues do here? This is my question.
I think it is safe side to start the procedure after seeing the ACT, but the experienced operator who is explained that 2 to 3 minutes we usually need to cannulate the engaged catheter. So it's a personal view, but it's ideally we should start with PTC procedure before after knowing the ACT.
Zoom.
It's my opinion.
Actually, Dr. Rian, but she has said that it makes good sense actually, because the ACT, the action of heparin reflected by the ACT takes some time. So it's not very necessary to wait until that moment, because the patient is already loaded with some antiplatelets before the patient reaches the Cathlab table. So I think it's no point waiting for the ACT to rise, because we check the ACT quite some time after we start the procedure. So I think it's safe enough to start actually, so without waiting for the ACT result.
My opinion is.
So I think I would agree with Dr. Ryan also, because there have been cases, for example, when you're doing a CTO, where you're concerned about a perforation, you probably would not want to anticoagulate the patient completely, and you'd probably give a small dose of heparin and then go ahead with the procedure. And only if you have got into the true artery, into the true vessel, probably, or you've done a balloon dilatation, it's then that we go for heparization. So I would also echo this thought that we probably need a small dose of heparin to start off with, unless you have a lesion which you have, you're confident enough of not really causing a major problem, that you could probably give the antithrombotic or give the heparin right away, and possibly not wait for the reports to come in, and you could proceed. And then, of course, half an hour down the line or 1 hour down the line, you could recheck. I think, and usually the protocol is we use 1 milligram per kg body weight to do the procedure. So if it's a small built lady, we'd probably give, say, 5,000. If it's a elderly, I mean, if it's a well-built man, it could go to 8,000. So there's no cutoff, but it's usually 1 milligram per kg. And if the patient has been getting a GP2B3, or if he's been preloaded with a low molecular heparin, say within 3 to 4 hours prior to the procedure, then the dose usually comes down to 0.5 to 0.75 milligram per kg body weight. So that's the normal protocol that we would follow here.
Thank you, Dr. Kaisar. Next, third, you go to the third, because we have long time to go.
So we have shown you how to do the femoral puncture, and we have shown you the angiogram. Now we will go for the decision making for intervention. It's very, very important, views and image intervention and how to do these things. So Motiur, next.
Thank you, sir, for nice discussion. Decision making for intervention, views and image interpretation. So with the diagnosis of after interpretation of coronary angiography, our diagnosis is triple vessel disease. Recommendation is revascularization. And we did syntax score, and syntax score revealed either PCI and CVG. So discussion and decision by the panelist.
So you have seen the angiogram, you have seen the ECG, you have seen the echo, and you know the history of the patient. Now my question to the panelist, expert panelist, so what would be our next step for intervention? Should we go for PCI or CABG? And if PCI, how should we tackle this disease? That is RCA proximal 70-80%, mid 60-70%, SARC 99 mid and 100% distal with reticular collateral, and LAD has got borderline block like 60 or 65%, and diagonal has got 70%. So can you play the angiogram again so that panelists
Sir, can you see the angiogram again?
Sure, sure. Motiur,
you don't mind?
Yes, Motiur, তুমি angiogram আবার দেখো।
কামরুল, শুধু angiogram দেখো, সব সহায় ফেলো।
শুধু only angiogram, nothing else.
Kaisar, how old is the patient? I forgot it.
Patient age is, I think,
60 years.
60.
55.
Is he diabetic?
Age is a CKD.
CKD stage 1.
RMI, inferior RMI is a 55 years old.
Historyটা আবার দেখো। দেখাতে পারো। তুমি উপরে গিয়ে হিস্ট্রি থেকে আসো।
তুমি হিস্ট্রি লাগবে না, তুমি এনজিওগ্রাম দেখাও। আমি হিস্ট্রি বলতেছি, তুমি এনজিওগ্রাম দেখাও। তুমি এনজিওগ্রাম দেখাও। Recent inferior RMI, ejection fraction 50%.
উপর উঠো, উপর উঠো।
CKD means you said the creatinine or GFR.
I think
whatever we
CKD stage 1, I think they stage 1 CKD.
Stage 1.
Creatinine কত ছিল 1.4 মনে না
Not bad.
Creatinine
Not bad. Not bad.
1.3,
Yeah.
but it.
উপরে যাও
শুধু এনজিওগ্রাম দেখা হয় ওকে
শুধু angiogram
আর
দেখাও
একটু উপরে যাও আর একটু উপরে যাও আর একটু উপরে যাও
এখানে
বাস।
Okay.
So you can
Then
see
go.
the SARC has got 99% mid and 100% distal with retrograde collateral from ipsilateral collateral. Next,
Okay.
LED has got 50-60%, 60-70% maybe borderline block in the mid portion, and diagonal has got 70%, which is a big diagonal. Next,
So this is RC.
so RCA has got 80-90% proximal and maybe 60-70% in the mid to mid portion. Big RCA.
Okay.
TVD,
Dominant.
TVD, it's a TVD with CTO, EF 45 to 50%, inferior wall hypokinetic, and other walls are good. And ECG has got Q wave in 2-3 AVF. Patient has got history of inferior MI getting into place in due time in another center 2 weeks back. And I think he's diabetic and CKD stage 1, that is creatinine, I think 1.4, like this.
Kaisar, we have two questions before decision making. Number one, CKD, how many dye you used for the fellows?
No.
About the dye. Number one is the views. Whose views is the
Mohsin,
important?
first we have to decide whether we'll send the patient for surgery or PCI. If it is PCI, then this question is coming up. Let us. No. Let us discuss.
You finish the angiogram first.
No.
আমি এনজিওগ্রাম কথা বলছি এনজিওগ্রাম শেষ করি স্যার একটু এনজিওগ্রামে যে বললেন আপনি যে মিড আরসিএ অথবা এলইডি ডায়াগোনাল দেখালেন you showed the diagonal and LED how the fellows decision taking the whose views are for the interpreted the lesions please show the views for the fellows junior fellows
Sure.
Yes.
Acha, Motiur, can you go back to areocaudal? Motiur areocaudal দেখাও আর একটু ব্যাক করো নেক্সট আগের স্লাইডটা ওকে আগের স্লাইডটা আসতে পারো একদম বলো হ্যাঁ এই বাস আচ্ছা now you have to take view according to the position of the lesion. In this view we can see the SARC well. So for the fellows I would say if there's a mid lesion of the SARC or you have to want to visualize the SARC, the good view is epicaudal, and for distal SARC you should do areocaudal, and for proximal or ostial SARC you can take aleocaudal. So for SARC, for this view is the optimum view showing the whole lesion here. Next, for LED mid lesion, I think epicranial or areocranial view is the best view. You can see the LED mid very well there, and also the diagonal. But for diagonal, you can also take aleocranial view. So for mid portion of LED lesion, these views are best. But definitely for proximal LED, you should see epicaudal or aleocaudal. Next, this is the aleocranial view. You can see that both diagonal and LED are separated well. Next. Now for RCA lesion, if there is a proximal lesion, best view is aleocaudal or aleocaudal view. For mid lesion, you can see plain aleo or areo view, or you can say also lateral view. For distal lesion or PD or PLV lesion, you have to take aleocranial or epicranial view. So views depends on the location of the lesion. Like in RCA, for proximal lesion or ostial lesion, best view is aleocaudal. For mid lesion, plain aleo or areo or right lateral. For distal lesion, PDA, PLV lesion, aleocranial or epicranial. Thank you, Mohsin. So can we proceed now?
Abdul,
Yes,
please comment.
now the
Abdul,
question is coming. Vital question is that this is triple basal disease with diabetes, with LV dysfunction, with mild renal impairments. So whether we should go for CABG or PCI. There is so many learned experienced operators here, including the Aftab Khan from outside. But if I'm the operator, if you ask me, then my decision will be I will do the FFR to the LED, 50 to 60%. If the FFR to the LED is significant, then we can think about the CABG. Otherwise, in this patient, there is no necessity to do there is no option for CABG. I think so. The multivessel PCI based option, but before that, I will do the FFR to the LED. And if the FFR to the LED is significant, then I will discuss to the family. Look, these are the syntax score. This is the, and after getting the consent, still I am, if the FFR is positive, still I am in favor, go for multivessel PCI in this case. I think so other expert may be the different opinion because RCI is a short segment, 2 tandem lesions. Diagonal and LCX, that's OM. OM is diffusely disease. Where the surgeon will put a graft? I could not find any point where to put the graft. And again, diagonal is also multiple segment lesion. Where the surgeon will put the graft? Only the LED surgeon can put a graft. But LED is borderline, so we have to make sure the LED is significant or not. If it is not significant, it looks 50%, 60%. If we do the FFR, LED especially, it could be significant. Otherwise, in LCX, RC, it should be non-significant. So I will do the FFR and will take the decision where I'll put the stents, multivessel. My recommendation is a multivessel PCI.
Thank you, sir. It's a very nice comment. Can we have comments of other panelists as well?
Dr. Fatima,
Kaisar, why you are doing the coronary angiogram? Why you did the coronary angiogram? What was the indication of the coronary angiogram, particularly in this patient?
He came to me with chest pain. I think chest pain on exertion, also rest pain. You can see there is a critical block in RCA. So I think it could be the cause of this pain.
Okay.
Sir, LV function showing the hypokinetic inferior wall and posterior wall. Hypokinetic inferior posterior wall on giving chest pain. Do you agree with the angiogram, Mr. Sir?
I have seen the angiogram, but it was very short view of echocardiographic view was little short.
Yes.
Now,
it was for a short view.
Why you are deferring that? This patient should not be an angiogram.
If the patient really
has
suffered from...
this patient must go for angiogram because this patient having a post-infarction patients and patient of hypokinesia and LV dysfunction, this patient, and there is no significance of the renal impairment. So why not? If you don't take the angiogram now, the renal impairment will be increasing more and more. So at the time, you will not find any time. So this is the best time to do the angiogram and to do the procedure and fix up that. Because if you don't fix up the coronary, then in future, if the patient develops severe renal failure, patient need dialysis, nobody will touch the patient. So this is the best time. No doubt about that.
I can add one more point because the patient having inferior myocardial infarction and there is no total damage because there is still persisting the R wave. There is Q wave definitely, but it's still persisting the R wave. That will demonstrate that there is a viable myocardium. So in that case, there will probable revascularization might help the patient.
The point is not viability and other things. Let me tell you, if the patient really had no chest pain, particularly in this case, you need to know the history of the patient.
Already been told patient having exertional dyspnea.
Yeah, if the patient do have symptoms, then you have the logic for doing this.
Professor Mishkat, another point is
you should have gone for other non-invasive tests to have the test because medical management could be equally good for this patient. He doesn't have any left main disease. He doesn't have any significant proximal LAD disease. Medical management would have been equally good for him had the patient being asymptomatic after the myocardial infarction. It is as simple as that because you have to communicate with the patient about all the choices.
Can I make a small comment here? This is Dr.
Professor Mishkat.
Sir.
Yeah. So
another thing.
Dr. Aftab Khan, please just Dr. Khalid Mohsin.
Please go ahead.
Khalid Mohsin, please.
Yeah. Actually, in a diabetic patient, we cannot expect some classical symptoms. So the patient is diabetic, and diabetic patient can have some silent myocardial ischemia as well as some atypical symptoms. So we should have this in our mind because we should not be carried away with the relative asymptomatic nature of the disease of the patient. So here we have to see if the objective evidence of ischemia as well, not only for the subjective evidence. That is my.
As the Professor Muskasar also told, he did some non-EC testing. Dr. Aftab Khan, please.
Yeah. So I think this is always a question that many of our referral doctors have, that should we intervene after the patient has had a thrombolysis, even if it's asymptomatic. This gentleman had some symptoms for sure, but even if the patient was asymptomatic, the question usually comes from the physicians that should you do an angiogram? And this is quite a valid question, especially when you have limited resources. Now, there have been many trials which have looked at it, Dr. Chowdhury. For example, in the stable coronary artery disease also, I think the most important trial that most people talk about is the COURAGE trial, where they say medical management is as good as intervention. But what we need to understand is that even in the stable group of patients where you have courage in the COURAGE trial, what you had is that the randomization into medical management or into angioplasty was done only after an angiogram. So the patients necessary for an inclusion into the COURAGE trial had to have an angiogram, and only then they were classified into either an angioplasty group or a medical group. So an angiogram was a starting point, even in the optimal medical management trial, which showed that possibly in certain group of patients, medical management may be as good as an angioplasty. But this was for chronic stable angina. But when you talk about acute myocardial infarction, I think we have enough guidelines to say that you must do an angiogram, as Dr. Abdul was saying. Without an angiogram, we cannot classify these patients into high risk. For example, this patient may have a left main disease that you may not realize unless you do an angiogram. He may have been lucky with an inferior wall infarct this time, but may come back later on and we may not get a chance to see him again, or he may end up having LV dysfunction, which will then prevent his LV from even improving. So I think there's enough medical data or enough guidelines to say that an angiogram is imperative. Coming back to Dr. Kaisar, I think this is an inferior wall infarct. So if I had to play the devil's advocate and speak from the side of the fellows, we have a lesion in the RCA and we have a lesion in the circumflex. And we all agree and understand that both of these lesions can produce an inferior wall infarct. And in fact, there's some lateral wall changes also. So if I had to do, if the RCA was thrombotic like this and there was critical lesion, and if the circumflex also was flowing with a critical lesion and not a CTO, how would you have taken a choice to decide which is the culprit, which was the one which has caused the inferior wall infarct? So that would be a question that many of us may have. Many times when we take these patients into the Cathlab, we see a double CTO. We see a circumflex that is occluded and an RCA which is occluded. And then how do you decide which one you tackle first, sir? So this is
Professor Meshkadaman, sir. Professor Meshkadaman, sir. Do you hear me?
Yes, I can.
It is a nice question. Please, would you please explain how do the fellows just assume which is inferior wall, LCX or RCA in these cases? Critical lesion. Yes.
Can I have the question again?
Dr. Aftab Khan told LCX or RCA, who is the critical lesion being the inferior amine in these cases?
ECG give a very good indication.
Dr. Motiur, please show the ECG. Dr. Motiur.
Which is the culprit?
Dr. Motiur, do you hear me?
Motiur ECG.
ECG, please show the ECG. This is a very much interesting question for the fellows. Dr. Motiur, do you hear me?
Show the ECG on.
Just ECG.
Yeah, okay, okay.
Yes.
Plus.
Yes, sure. Big on. Meshkar sir, please explain the ECG.
One APA there. So the 2-3 APA. So then this calculation is ours. That was the OAM, principal way. That was not else.
Dr. Meshkar sir, do you show the ECG?
Yeah, I can see the ECG. It seems to be RCA is the culprit lesion.
Correct.
Yes, sir, please explain, sir, for the fellows. Previous slide, please. Motiur. Khalid Mohsin, sir, please.
Actually, the ST elevation in inferior myocardial infarction is relatively transient compared to the anterior myocardial infarction. But if we compare the magnitude of ST elevation between lead 2 and 3, sorry, lead 2 and 3, if the ST elevation is more predominant in lead 2 compared to lead 3, we think that it is a RCA lesion, and if the dominance is more in favor of lead 3, it is likely to be a dominant circumflex lesion. But when the ST stabilizes,
I think Dr. Mishka, I think we just reversed it. Just the reverse.
A little bit wrong. If it is the ST lesion is more in lead 3, then it's RCA lesion. If it is more in lead 2, then it's
sure.
Yes.
And also, sir, B1, B2, and later leads, sir. Wadud, sir, please.
And the thing is, look at B2, a very tall arm with a very upright keyword. That suggests in the context of inferior MI, there's a big posterior MI.
So I think it's the acute ECG that gives us more of an idea whether it is an RC or a circumflex territory. So in the acute MI, if you have a lead 3, ST elevation in lead 3, which is more than lead 2, you have to understand that when you look at the limb leads, the 3 is towards the right side. So you have a right coronary artery which is occluded when you have a lead 3 which is more than lead 2, ST elevation in lead 3 more than lead 2. And if you have an ST elevation more in lead 2 than lead 3, usually with the V1, V2 changes also, though they go more in favor of a circumflex infarct. And of course, conduction system delays will also go more in favor of a right coronary artery rather than a circumflex. So here, when we see these double lesions, I think we understand here that it's the dominant right coronary artery, which is now supplying branches to the lateral wall also. And this V5, V6 can very well be explained by the dominant RC itself. And I think Dr. Azulur made a very pertinent remark about the strategy for this patient. I think the LED is something that you should assess by means of flow reserve, whether it's an FFR or an RFR, to assess this criticality of the LED. And if the LED is, as in most likely probably be non-critical, only the fixing the proximal RCA may be good enough. And I think we probably nitrate the mid part to see whether there really is any significant lesion in the mid RCA, or probably we can do an RFR or an FFR in the mid RCA after you've tackled the proximal RCA. So I think I'd go with Dr. Afzalur Rahman's sort of approach in trying to tackle this lesion, sir.
Thank you, Dr. Kaisar. Nasrullah Khan, please continue your cases.
Okay. Now, thank you for all the comments of the panelists, and I would say the fellows learn from each leaders.
Camera to the Dr. Kaisar.
I'm a very small person here. Whatever the leaders said, like Dr. Aftab Khan, Dr. Mishka, Dr. Afzalur Rahman, they have given very comment, and you can see in different ways to a lesion, and you can do it differently. But ultimate aim of all of us is doing the best for the patients. So we all learn from each other. So what I did, I would say that I talked with the patient about the TVD and also the both options like cabbage and as syntax score was low, 21. So outcome of PCI and CBG is almost the same, and patient opted for PCI. So what I did, because this is a learning objective, I have to show a simple case. So I did the CTO, actually RC was the culprit lesion. He got tentative place within, I think, 2 to 3 hours. So it worked there. But SARC was a CTO because it is getting retrograde collateral from LED. So I did the CTO first 2 days back. And today I kept the case for RCA and also by image guided RCA lesion. And then I will, what Abdul said, I will do an FFR of the LED. If it is significant, I'll do LED also. So I'm starting with the right. Can I have the right catheter?
Please stop sharing. Please stop sharing.
Kaisar,
please stop sharing.
Can I say something? In this patient, syntax score is no value for deciding the CABG or PCI.
Why, sir?
Why? What will if the syntax is in this patient syntax score, because LED is the determining factor. Here LED is the determining factor. Whether you have given the option to the patient for surgery or CABG. But before doing the FFR to the LED, you cannot give the option to the patient. This patient may need for surgery. Because if the LED is not significant lesion, this patient should not send up for surgery by any means if the patient wants that I would like to say the surgery.
In practical life, things doesn't happen what we want to see in the books, because this angiogram done in a different center 2 weeks back after the MI, and there one of our colleagues has said for cabbage, and then after 2 weeks patient come to me with an intention if PTC can be done or not. So I discussed the both things.
Professor Mirjamaluddin, sir. Professor Mirjamaluddin, sir, do you hear me, sir? Yeah. Professor Mirjamaluddin, sir, do you hear me? Please unmute, sir. Sir,
Yes.
regarding this lesion, what your strategy, sir?
Overall,
Now, the angiogram, sir, in the angiogram view, which was your option for revascularization CVG or PCI or IBAS FFR? Which choice?
I think, Professor Abdul, I have heard entire program, but doing another work simultaneously. Anyway, Professor Abdul sir has very nicely pointed out that I shall have to see whether the LED is critical or not. If FFR is positive for LED, and then LED becomes critical, then it is TBD and diabetic patient with low EF. So
Normal EF, normal EF.
Normally, surgery, even then surgery will be the first priority. And if LED is not critical, FFR shows it does not critical, then I shall have to do LCX, OM, as well as RCA, PCI. And LCX, OM, PCI, preferably I shall do it first, as because it is almost total occlusion. I shall have to try it, I shall open it, and then I shall do focal 2 lesions in the RCA. This is my idea.
Thank you. Thank you, Jamal, for your
Mohsin, I think Abdul sir is absolutely right. If you don't have the LED involved, then there is no question of going for surgery. And if there is no question of going for surgery, no use of syntax score.
Okay, one question is that what if we do not have FFR? Then how do we do? Just for our fellows, if we do not have it, and for the money also. It's very important.
Apparently, it looks like non-critical lesion, what Kaisar Nasrullah told, 60 to 70% marginal lesion. So I do not want to treat if I have no FFR there.
Good.
Yeah, it's a very, very important question raised by Dr. Riananis, because 90% of our lab does not have any IFR, FFR, or IVAS. So in practical field, you have to determine it by your eyeballing method and your clinical intuitions. So that also my suggestion to fellows, that you have to see that whether there is symptom, or you can see the EKG, you can see the echo, whether there is a hypokinesia, and also eyeballing things. So all of these things without IFR, FFR will help you to take a decision. And we also get like FFR IVAS, I think just 2 or 3 years back, not before.
So let's start our work. We have a long time start our work. You start doing PCI.
Sure. I'm enjoying the expert opinion of our. Yeah, can you show please here? So this is our guiding catheter. So I'm getting it in. So as is the basic course, so I'm showing everything from basic. So first you have to, can you please show the fluoro? First you have to push the wire first, not guide catheter. Be careful.
Dr. Kaisar, you are doing a dominant RCA intervention. Would you like to have a venous line for our beginners or the fellows for an additional safety measure?
Yeah, you're right, Khaled Bhai. We should have taken a venous line, which I have not taken, but ideally we should take a venous line. You're right. You're right.
No, Kaisar, it is not no need.
No.
Kaisar, it is not need. And already you have fixed up the LCX. So there is no point of giving the venous line in this case.
Yes, 90% case you do not venous line. Dr. Aftab Khan, you do the venous line. Dr. Aftab Khan, you do the venous line.
Yeah, so I think these could be a difference of opinion. What we would probably do is in the initial periods, yes, we could probably keep a venous line, but usually because he's been already treated with clopidogrel and dual antiplatelet for long, he's already had his other arteries fixed, as Dr. Abdul has said. In Allah, probably we would not do it, but I think as a learners, I think for the fellows, you should probably initial phases when you're starting off, it's safer to keep a venous line. Experience
fellows, you should do the venous line at the beginning.
So I've taken the guide catheter with wire. Fellows, remember, first take the guide wire, then the guide catheter. Never take guide catheter without the wire. If you take guide catheter without the wire, you can rupture a plaque or calcify plaque in the aorta and cause a minor stroke. So I hooked the RCA. Now I'm taking a shot, and as it is a proximal and mid lesion, I'm taking first LO. LO cranial. Right. So you can see there are two lesions. Proximal one is definitely significant, but mid one is borderline. So we'll do IVUS.
Dr. Kaisar, can I make a small comment here?
Sure.
Yeah, so I think radiation is also one of the important things that all fellows and everyone who's working in the cath lab should be aware of. I
Sure.
can see that you're at 15 frame per second for your normal work, and that's usually the default. We have moved on to 7.5 frame per second because I think we all need to understand that when you're in the cath lab and you've been there for almost 20 years, radiation hazards are real genuine. And though most of the labs have come down to low fluoros, working at 7.5 may give it a little grainy appearance, but usually it is good enough for most of the procedures. And that's one small suggestion that.
Yeah. I totally agree with you. But for today's case, I'm keeping everything grainy. So can you focus here in my hand? Listen. So you can see this is a BMW wear. This is my workhorse wear usually. I've given a curve in the tip, small curve.
Off the light, please.
Light off कौन बोलते हैं?
Light off कर, but slow correct, low down. Light.
Now you can see.
Exactly right. Very good.
So you can see there is a bend at the tip, small bend, which will show the. You can take the wire very easily because sometimes if it goes to a branch, if there's a curve, then you can twist it and take in the main vessels. So always give a gentle curve in the tip.
Kaisar bhai, how the curving the proximal and distal curve? How the fellows is the curving the proximal and distal curve? Is the vessel tortuosity or lesion plaque? Dr. Aftab Khan. Dr.
Yeah,
Aftab?
so I think there are two types of curves. There is what we call as a primary curve, and there's a secondary curve, which is more proximal. So in most of the cases, you need a primary curve is good enough because then it is easier for you to, because this is a straight wire. Most of these wires are not pre-shaped. So there are two types. You can get a pre-shaped J or you can get a straight tip, which you need to shape according to your intention. So as Dr. Kaisar has done, he's given a primary curve. So where he's just made one angulation at the tip, usually at an angle around a few centimeters from the tip, or millimeters rather, not even a centimeter, millimeters from the tip. And if you had one more curve,
please show the Dr. Kaisar hand. How the torque, please. Camera, please.
Hand here.
Torque.
Okay.
Dr. Aftab, please continue. Dr. Aftab, please continue.
Yeah, and if you had made one more angulation proximally, which is known as the secondary curve, it makes you easier to enter into very curved or tortuous vessels. So if you had an obtuse marginal that you needed to enter, you probably could have made a secondary curve also. But for a straight artery like this, a primary curve is usually good enough. And I think he can, with his skills, he should be able to possibly negotiate into this distal vessel quite easily.
So about curve, because this is a 90% lesion, so we give one single curve, like 1 to 2 millimeter, a small 45 to 60 degree curve. But in situ lesion, usually I give two curve, one primary, one secondary. Primary one just 1 to 2 millimeter from the tip, which is usually 60 to 90 degree, and another secondary curve 3 to 4 millimeter away from the tip, which is 45 to 60 degree. But in this case, as this is 90% lesion, I give a single curve. So you can see my wire is in the RC ostium. Can I show my hand? So I'm pushing and pulling by this, my left hand, and torquing with this right hand. So you should torque with right and left hand. Just navigate the tip of the wire and push and pull by your left hand. Okay. So let's try, see. So you can see when there is a wire is bending up, that means it's not the true lumen. So then never push it. Just pull it back, rotate, and again it's going. Can I have a check? It's gone to a branch. Check. So you can see it's gone to a branch. So I pull it back, and then it jumped away. Again, I think it's gone to small branch, but now it's in the main vessel. Again, branch. So when you go into branch, don't panic. Just pull it back, rotate, and then go. So never ever push a wire when it buckles. If it buckles, you should think either it's gone to branch or it is into a plug. So just pull it back slightly, rotate the tip, and then push forward. And remember one thing very careful for the fellows, if your wire is the true lumen, it should go very smoothly. You do not to give any force, except in CTO. So now I'm through to the lesion. So I will try to go as distal as possible.
I think it may be worthwhile for the fellows also to understand that this, since it's a BMW, the distal radiopaque part is 3 centimeters. So that wire can often be used for measuring a lesion length when you're going in also. So that is something that we use often to measure the length.
Yeah. Dr. Aftab Khan has given a very important point. Okay, I'll do it. Okay, Tanvir, take a shot. So this
Dr.
is just
Kaisar,
for
whether you are
measurement.
going to fix up the mid lesion?
No, just for measurement. What Dr. Aftab Khan says, take a shot, small shot. So you can see this is 30 millimeter. So another maybe 30 up. So total 60. If I do the full lesion.
Whether you are going to fix up the mid lesion, what is the decision?
Yeah, I'll do IVAS.
Oh, for fixation of the lesion, IVAS has no role. It is the FFR or IFR or DFR that has a role to decision whether we'll fix or not. IVAS is the role to see the plaque morphology and also how the stent is deployed. But if you take the decision that whether you will fix it the mid segment, then you have to go to the FFR, not IVAS.
Sir, what is the decision could be here, seeing the lesion in the mid segment, and the proximal segment is very significant, no doubt about it, to make it fix up. But whether the mid lesion, whether you are going to fix it up.
Then
visually.
If visually, if you have no IVAS or FFR, then I will fix up both of that.
Exactly.
But if I have an FFR, then definitely I will go for the FFR. If the FFR shows that the mid segment is significant, then I will fix up. If not, then I will not fix
then
up.
you will fix up first proximal lesion, then do the IVAS or FFR, and then we'll decide.
No. If I have an IFR or DFR, I can see both the lesions significant or not. That is the point. But if in my lab has no FFR IVAS, considering the RS size, RCS size, the big size, so I will fix up the mid and also the proximal segment.
So
but
visually, what would be the lesion size? Stenosis in the mid segment, visually, sir.
Visually, it is 30, maybe 33.
No, sir. Stenosis percentage.
Okay.
Oh, stenosis.
Sir, as time is short, so we need to proceed. So
Yes, sure.
I totally respect everybody's opinion, and there are different ways of dealing a lesion. And what Dr. Abdul said, he definitely is a very expert opinion. But for this lesion, I think that I will do the proximal one. It is mainly for pre-imaging. So I do IVAS before lesion to see mainly the size of the vessels, my stent size, length of the stent, and also the nature of the plaque. And he's right.
Exactly.
But even then, you can have an idea of the plaque burden. And if it is more than 70 to 80%, we can do it as well. This is another way, but IFR will be more accurate. I totally agree with you.
Dr. Kaisar.
Yes, I do right.
So just give me a minute, sir. Just give me a minute. I will do the IVAS, then we'll talk. IVAS should
Yes, you go ahead, because time is short.
Time is short.
1 hour is finished.
Because
1 hour is
I want to
finished.
finish in a time.
Yes,
So you
sure.
can see, bookmark. There is a plaque. You can see the IVAS. There is a plaque, I think 6 to 12 or 9. But not
We are not
seem
seeing
so.
the IVAS. We are not seeing the IVAS.
Now this is a very, very serious plaque here. Bookmark.
Please show the IVAS.
So this is the
picture.
mid lesion. This is the mid lesion.
Show the IVAS picture. There is no IVAS picture here.
IVAS picture কোথায় দেখাও IVAS picture দেখছে না দেখাও
Fix the camera over IVAS picture.
At the top of the screen.
No, IVAS should be connected.
We see the IVAS, but you see the monitor image, please.
IVAS দেখছে না
হাতে
Ikuna, please.
ক্যামেরা দিয়ে দেখো অফ করো
IVAS is not.
We can see it at the top of the screen.
অফ করো এটাকে অফ করো
ক্যামেরাটা খুলে
এখানে
নেন।
Only see the IVAS monitor.
You can see the IVAS now?
No.
Okay.
Okay, we see now.
Okay,
Thank you so much. Shaun, thank you.
No,
Okay.
you are seeing there.
Record হইছে
Yes,
You are
sure.
sitting there, you're seeing there, but it's
Second,
not in the
second.
screen. in our
I was
screen.
the
Zoom
you can see
screen.
the IVAS now?
No,
Yes,
it's not
sure,
in the
sure.
Zoom screen. It's not in the Zoom screen.
Now you see
Zoom
the
Zoom Dekhan.
Yeah, now it is visible. Now, yes, now okay.
Okay, Charan. So you can see there is a plaque from the 6 to 9 or 11 position now, eccentric plaque. Now it's concentric, but not significant. Here the plaque seems very significant, especially in this portion. This is the mid portion, which we were saying that it's not, does not seem so much tight in the angiogram. So again, normal. So we left the mid lesion. Now we are coming to proximal lesion. So I think this is a proximal lesion. This is the proximal lesion. Lumen is very narrow. Okay, this is the proximal lesion. Okay, so according to IVAS, can I finish? So
yes,
according
please.
to IVAS,
Yes.
according to IVAS, it seems that both the lesions are significant. Proximal was no doubt it can be seen in angiographically, but mid one, which was not seem so much tight in angiographically, but here it seemed almost maybe 70 to 80%. So I'm measuring the length, which can also be measured by the distal tip wear, which Dr. Aftab Khan said, and I'm measuring the normal vessel diameter, stent size. Then I will maybe after seeing this IVAS result, I will do the whole lesion. Maybe it might require 2 stents. Any comment, please?
Dr. Kaisar, yeah. What I'm saying for the fellows, especially if they have IVAS access there, because just for the lesion severity, IVAS is not actually the popular means to understand the severity of a disease. That is one thing, and another thing is that which I am telling very much like Dr. Kaisar, whether if the lesion proximally is 95%, in that case, without pre-dilating the proximal lesion, you are doing the IVAS, you are taking the IVAS catheter. Is that okay for you?
Yeah.
Because when you are taking the IVAS catheter, sometimes for a long time, you are actually occluding the RCA. Sometimes. So in that case, which one? So this is very important because IVAS takes a long time. It's a long run there. So it's better to pre-dilate the proximal lesion, which you know that it is severe, and you are going for the mid lesion. That one you can do the IVAS. Then comfortably you can do the IVAS.
Distal vessel normal says it again.
This is a very important point, Dr. Aftab.
Yeah, I think that point is well taken, sir. But I think this was an artery which was flowing, and there was a lumen of at least 2 millimeters. Now we know that this IVAS catheter has a caliber of 1.2 French. So
yeah, but you don't know the proximal lesion has a plaque burden also, you know.
Right. So I would agree first with Dr. Abdul that probably the intention of IVAS should be to know the nature of the plaque, whether there's calcium, whether there's fibrosis, rather than to assess the severity of the lesion. We have done it, and therefore, even after before doing an IVAS, the guidelines or the recommendation is to use a good amount of intracoronary nitrates to make sure that you've adequately dilated the lesion. Otherwise, as you said, once the catheter goes down,
normal vessel,
distal spasm,
normal
and you can make your assessment of the distal lesion can be affected by the coronary spasm that can set in. So giving good nitrates during this lesion assessment is also
normal vessel.
And I would agree with you. Yes, you should probably dilate the proximal part because it's critical, especially when you don't have a temporary wire.
2, 3.
Yeah, you know, it is safe.
Dr. Saiju, not only for the IVAS, but if you dilate the proximal portion, you can have an estimation about the mid segment. Traditionally, we did the proximal segment, so we could assess the mid segment.
Yeah, that is also possible. Actually, for measuring the lesion severity, IVAS is, if you want to stand, do the IVAS. If you don't want to stand, do the FFR. That is the general principle usually. If you really want to stand,
my point is, if you dilate the proximal portion, you can have a good estimation about the mid portion.
Obviously, and also the flow in the mid RC would be more, and then you can predict the severity more. That is
for the fellows, Dr. Aftab Khan, You do all the cases angioplasty for pre-dilation of the lesions of all the patient. You do the pre-dilation. Any lesion?
Sorry, I didn't get you. Pre-dilation prior to an IVUS, is it?
No. Any lesion, you do the pre-dilation for the fellows for the all cases.
Yes, so I think there is enough data to say that yes, a pre-dilatation is better because it helps you to assess the nature of the plaque. If you don't do a pre-dilatation and you end up with a calcific lesion there, you sometimes would get with an unopposed or an unexpanded stent, which can land you in trouble. So now that we have an IVUS here, which has shown us that there's not much of calcium, but here I would definitely say that yes, 90 to 95% of my lesions are pre-dilate. The ones that I would not pre-dilate probably would be the large thrombotic burdens, where doing a lot of pre-dilatation can make the distal thrombus migrate into the distal bed. And those could be the lesions where you probably do a direct stenting. But in patients, otherwise, yes, it's always safer to pre-dilate first before you take your equipment down.
Yeah, Dr. Aftab, this is actually Mohsin has asked a very beautiful question, because if you just can remember, a beautiful trial was the DISCO trial. Can you remember that one? The DISCO trial, there is the pre-dilatation versus without pre-dilatation, the provisional stenting or conventional stenting or the direct stenting. The direct stenting causes minor myocardial injuries less. So if sometimes if you don't do a pre-dilatation and you can easily predict that you can actually put a stent, then in that case it's better not to pre-dilate. If you see that some calcification, proper vessel bed preparation is necessary, in that case obviously pre-dilatation is necessary.
Yes, but
otherwise
what
not.
I said, yes.
Like
Aftab Khan, Dr. Khan, do you tell something about the mechanism of pre-dilation for the fellows?
Yeah. So
how
for this,
lesion, just for the fellows, for the beginners.
So I think I agree here that there could be two ways of looking at it. As Dr. Saidur Rahman just said, when you do a pre-dilatation, you could basically cause, the mechanism of pre-dilatation is to cause a intimal flap. Basically what you're doing is that there is a tight lesion there and there's an unyielding plaque that is there. You want to create a lesion with a balloon, which you usually use a 1:1 sizing balloon, or you downsize it to a 0.75 to the vessel size. Usually it is a 1:1 sizing that we use, or a little lesser than that. And then what you do is use nominal pressures to make a lesion, make a dilatation so that the lesion opens up. Now, if you have a calcific lesion, many times the lesion may not open up, or it may open up eccentrically, or it may not open up at all, and what we call as dog boning. So the edges of the stent of the balloon may open up, but the center part, which is critical, may not open up. And this will then give you an idea that you have to go more high pressure. So rather than nominal, you may need to go high pressure. Now, the downside of it is that because you're doing this balloon dilatation, you cause a intimal rupture, intimal dissection, not a rupture, you cause an intimal dissection. There could be some myocardial injury, there could be some trauma with distal microembolization. But in this patient who is an elderly man, 55 plus, who has a CKD, who is a diabetic, the chances of having intimal calcification is much greater, even though if you don't see it angiographically. And therefore, an intimal pre-dilatation is something that I would strongly recommend, because it will tell me how good the lesion is, how compliant is it, whether there is calcium that is there, whether my stents will open up fine. And in this case, for example, once I do a pre-dilatation of the proximal lesion and I give good nitroglycerin intracoronary, make sure that the mid lesion may not be as critical as we are seeing it if we do not have an IVUS, for instance.
IVUS.
For my opinion, without primary PCI, all the cases should do the pre-dilatation for the beginners or fellows. Because for the beginners, we have not the IVUS or FFI in the Cathlabs. How the lesion behaves, the fellows shouldn't know. So should do the pre-dilation for the beginners. Should do the pre-dilation. Dr. Aftab, you agree with that?
Yeah, I think that's what I said. When there's a thrombus lesion where you're worried about causing a pre-dilatation, those are ones. I don't see much of a reason for not doing a pre-dilatation. It takes a small amount of time. It makes my bed that much better, and it gives me a greater confidence to know what exactly is happening there.
Thank you so much. Nice opinion.
I just want to add, I agree with you. I mean, if there's primary, you don't need to do pre-dilatation, but sometimes, we have patients with non-STEMI, single vessel disease, and it, you look at the angio and there's single vessel and it looks like a typical soft lesion. And especially if the patient has CKD, then, for the fellows, I want to say, it's not the type of dye you use, it is how less dye you use. So if you think you can get away without pre-dilatation, and if it's a single, soft, you can you know, from experience, you can say whether these are soft lesions or not. So, I mean, not always would I encourage predilatation.
Actually, the fellows, they dislike predilatation because they are always in fear of losing the wear position when they are pulling the balloon out. So they are more inclined for a direct stenting. So you have to, yeah. So therefore, they should be prepared to prepare the lesion first, and particularly in elderly patient, diabetic patient, CKD patient. So they should be, it's by default, this will think that this is a calcified lesion, even they don't see the calcification on fluoroscopy.
Khalid bhai, in real life, what we are doing actually, because we are taking, whenever a little bit experience they will gain, they will take the stand and the testing it a little bit, whether the stand is easily going, crossing the lesion or not. If it's not crossing, a little bit hurdle is there, pull it up and do a predilatation. More contrast is used, and you have understood that you need a predilatation well to make a vessel bed preparation. That's a real world scenario, You can do that way.
Yeah, both has got the advantages and disadvantages. I think the operator's discretion has to be exercised.
Fluoro main screening.
For the case, Dr. Kaisar, please continue.
Okay, so we did the IVAS, and IVAS give me 3 information. One is size of the distal vessel. It is almost 3. And it also give me the nature of the plaque, which seems to me not fibrofatty, and no calcium is there. So I'm taking a 315 balloon for predilation because size is 3, so that I can see that I optimize the my lesion before putting a stent. So this is I'm taking it down. So go up, nominal. Okay, down.
Okay, ready kor ami astechi.
Again, go up. So, 14, 16, 18. Down. Okay, I did the mid lesion. Now the proximal. Go up. It is 3.5, so I'll go high pressure 20. Down. Go up. It slipped. So can you give it down? Small check. Wait. Small check. So I didn't like the main lesion. So 2, 4, 4, 6, 8, 10, 12. You can see dog boning. 16, 18, 20. So you can see that down. You can see that while doing the dilation of the proximal lesion, the balloon slipped. So I inflate the balloon very slowly. So the both end inflated first, then the last mid part last. It's called dog boning effort. That's to hold the balloon in the lesion and take it out. But as it is not giveaway in the middle, I will take a 3.5 balloon to dilate the proximal lesion because the vessel says 3.5 before putting the stent. 3.5 balloon, please. 15. 3.5, 15 though? Fast.
Kaisar, it looks like it's
Dr.
opened up.
Kaisar, it doesn't look like that much calcified, is it?
Yeah. It's opened up.
It doesn't look like, but while can you show me the picture? Minus.
Why this melon? Why this melon seeding is there? Why
So
the melon?
it could be some fibrous plaque.
Fibrotic, I think. Too much fibrotic.
Now, plus, hey, hold. You can see the both side open very well, but the mid portion still there's a cleft there.
Dog boning effect.
Can you make the
You have taken your balloon up to the ostium of the RCF?
No.
Dr. Kaisar?
No.
Taken the balloon up to nearer the ostium?
I've taken near the ostium, not up to the ostium. Check. I'll show you the check. Check.
Okay.
Okay. Take a shot to show everyone because they're confused with ostium.
But the fellows, you should prepare
go
the
up
bed
246.
Dr. Kaisar always high, upsizing the balloon
down
2 to 3. So you should prepare the bed properly before starting.
Balloon
It's
burst.
mandatory for the good procedural success. Dr. Khalid Mohsin, please add in this preparation of the bed.
246.
Yeah, actually, we should be guarding against surprise, actually, because we need to evaluate the behavior of the vessel before we put the stent in. So the pre-dilatation can give us an opportunity to assess the character and the behavior of the vessel. So before, if we leave an under-expanded stent, it can lead to a lot of problems. So I think it's better to check before we take the stent in. We must be absolutely sure that the stent is going to oppose to the wall to the best of the opportunity. So that's very important.
Dr. Khan, do you hear me?
Yeah. So I think,
please,
I
comments.
think just a small request. I think the distal wire is really moved to distally. If that could just be managed, because I'm a little concerned, even though it's a soft, it's a floppy wire, it's probably gone to a too distal and it's folded there. So that's what my small request would be to Dr. Kaisar, to just manage the distal wire first. The second issue is that I think, as all the operators have said, I think surprises are something that we don't want to do for a simple lesion like this. Pre-dilatation, good preparation of bed is absolutely essential. The last thing we want is after you put a stent and then you're going very high pressures to try and inflate an unexpanded part. Always better to pre-dilate, create a good bed, and then go for
3.533.
Tanbir, you please look at the wire, distal part of the wire.
Wire distal tip.
Distal wire plus folding the wire. For the fellows, it is the floppy wire, but sometimes with the hard wire, so injure the distal vessels.
338.
Most important part for the assistant.
It's a very good suggestion by Mohsin. I agree with him. Though it is a BMW wire, but even then we should not fold it in the distal.
So Dr. Kaisar, just my question to you. Now you've done a IVUS, and how do you size your stent requirements? So what is your guideline for sizing?
Yeah, in IVUS, before the stenting, pre-imaging, I did take the distal reference vessels. So I took the stent length, both by IVUS and by your method, which is distal tip, radiopaque tip. It seems to me like 63 or 64 in length, millimeter. Second is that the sizing, distal size is 3 millimeter of the RC vessel, and proximal is 3.5.
No, so what I would like to know is that the measure of the sizing, has it been, there are two methods of sizing. One is you can do intima to intima. That is one method, or the other method is EEL to EEL. You can do the external elastic lamella to external elastic.
Now I'm taking the stent, so you can see it's going very smoothly. So that's a good stent, Alpine.
So what we normally do is that if the intima to intima is 3, we usually would upsize by a 0.25. So we take a 3.25.
Yes.
If you're taking an EEL to EEL, you probably downsize by
0.25. Yeah,
so
you're absolutely right. Yeah. So I'm taking the stand now. It is 338 now. Okay. Can you please take a small shot? Go.
And for the fellows, again, the sizing has to be for the distal reference. You don't look at the proximal vessel size and take your stent. It always has to be the distal reference vessel that decides your stent size. Stent diameter, that is what I mean.
12. You can see the mid part still did not give away. So I have to take a small balloon and then go high pressure in with this thing.
3, 12, 15.
Usually I keep the stent inflated for 20 seconds for good apposition. In Japan, they do it 3 times, 20 seconds each, but I do only once. 20 seconds, okay. Down.
20.
So I'll take a small balloon, I think 310 or 8 to do the.
So this balloon, when you're coming out, can again be used for a sizing of your next stent, I think. When you're taking that, this 38.
So I'll go some high pressure proximally, because in distal reference vessel is 3. So if I go high pressure, it might dissect the distal vessel. So I will take the balloon inside, and then I'll go for high pressure. Go 1820. 1820.
20.
The other important thing, Dr. Kaisar, as the fellows, I mean, just for them, they would have noticed is that when you're pulling back the balloon, one has to be very careful of the ostium or the guide position. There's a tendency sometimes when you're taking long stents for the guide to deep throat inside and dip in. And one has to be careful to either anti-clockwise and de-rotate the guide so that it does not get sucked in, or make sure that you're careful with the proximal guide position. Because this is what happens when you're doing it off floor. When you pull the guide back, your balloon back, the guide can get sucked in and it can cause a major dissection in the mid part of the RCM.
Dr. Aftab Khan, do you tell about the stent quality? Is the Giants Alpine also, which stent is choice for the fellows? For the which stent you choose in cases?
Yeah, so I think now we've got all these
for the
stents
fellows.
with all the 4th generation stents are good enough. They're all low strut thickness stents, anywhere between 70 to 90 microns. So I think the Alpine is a good stent. It's a good trackable stent. So here, I don't think so. I would have a particular choice. I think this
10, 12,
is
14,
14.
18.
So here, Dr. Kaisar,
Down.
you've almost at the proximal part of the stent, or what is the length? This is a 38. So you think you'll need another
Down.
38?
So I'm showing you again the picture. Then you can. I took according to your advice the instant balloon in the proximal portion to measure the things. So you.
So probably a 34 may be good enough. I think.
Minus. Now you can see I'm aiming for the proximal branch there in the RCA proximal portion. So this is a 38 balloon. I think 33 will be okay here.
Yeah, 30 or 33 should be good enough for you.
33.
3.5.
How much overlapping the Aftab Khan? Overlap the stent for the fellows? Overlapping
So
for
I
the
think 1 to 2 struts is good enough for overlap, because as I said, these stents are now much better than the earlier duns that we had. The only thing is that because they are not as radio opaque as the earlier days, one has to be a little careful, probably do some method, go more caudal, do a stent boost or other technologies to make sure that you have a distal overlap of at least 1 to 2 struts. That's more than enough. If you have a lot of problem and if you've taken a long stent and you do a major overlap, you're probably, these stents are more forgiving than they were in the earlier days, because these are thin strut stents. But I think 1 to 2 struts overlap is good enough. You don't need a major overlap.
The fellow should know the balloon marker for the stent. For the Giants, it is the balloon marker. I think it is the just margin of the stent. I think so, Dr. Aftab Khan, for the Giants.
So there are some stents which have a stent that is after the balloon marker. Well, here the Giants usually it is from the balloon marker. So
the balloon marker.
The stent just starts at the level of the balloon.
Yes.
So I'm stacking in the proximal edge of the distal stent. You can see I not go down. So first I'm trying to take the guide catheter more in and ask the patient to take a deep breath. Lamba shashten baba. So you can see I am now a bit in, but even then not okay, now in. So sometimes the proximal edge of the distal stent might obstruct the proximal stent to get overlapped. So at that time, you have to make the guide catheter more coaxial for giving good support and ask the patient to take a deep breath. So it changes the orientation and takes the stent inside very easily, like this case. If I would have failed in this case, then I would take a second body wear. So the second body wear can change the orientation of the curve and take my stent more easily.
Thank you, Dr. Kaisar. Dr. Aftab Khan, regarding this, you can any tips for the fellows?
Yeah, so again, I think one more view is that you look at as an REO view. Sometimes if you go into an REO view, once I think Dr. Kaisar, he's working now, so let him work. Sometimes your guide may not be coaxial, and making it coaxial in an REO also makes your stent go in that much easier. So what is important is not to just keep on pushing. Pushing does not mean that your stent will get in. It's more important is to do the small maneuvers to make the guide more coaxial. Sometimes we think that just by pushing your stent will go in. If you push very aggressively without being coaxial, the entire system can fall out. Your guide and everything can just get disengaged.
One thing to know, Dr. Aftab Khan, when you placing the stent in the ostial part of the RCA, what are the tips you should, how the tips of the fellows?
Yes. So I think again, the ostium, that's a wonderful question. Now we've kept it away from the ostium, but there are cases where we need to make sure that we are covering the ostium. So there are certain views, as Dr. Kaisar has said, for the caudal view, if you go more eleo-caudal or the spider view, the ostium is better visualized. So one could do a caudal view. The thing is to put another wire. So you could take another wire and put it in the aortic cusp onto the right sinus. So what will happen is that that wire will prevent your guide from getting into the right coronary artery, and you push your guide in, and then you can pull back the stent so that you know that you are into the ostium without missing the ostium. So gaining triangulation and using a wire in the right sinus another wire to prevent your guide from dipping into the ostium may help you to get an accurate ostial positioning.
So I push the balloon a bit on the mid portion to go in the high pressure to oppose the overlap portion of the both stents. So I'm taking the stent balloon inside the mid portion and going up. Go up 10, 12, 14, 16.
3.5 balloon.
So this is I've done for optimizing, opposing the both stent well, the overlapping portion down. So still there is some indentation in the proximal portion of the stent, which may be due to that the fibrous plaque there, which did not open up well, maybe with even with 3 balloon. I've taken 3.5 balloon. So even with all the stent pre-dilation with 3.5, 15 balloon, still you can see there is some indentation of the stent. Minus.
So I think what I would suggest, Dr. Kaisar, I think is that many times, so when you did an IVUS, I thought that the proximal RC was almost a 4.0 rather than a 3.5. So angiography and an IVUS usually would tell you a little more vessel diameter as compared to an angiographic imaging. And you would be surprised on finding what you see on IVUS. So you can go with a 3.5 balloon at high pressures. So the question then becomes, should we take a 4 and go at nominal, or take a 3.5 and go high pressures? And the answer is usually that taking a lower balloon and going higher pressure is sometimes better than trying to take a 1:1 size balloon and going at lower pressure.
3.6 inside.
Dr. Aftab.
3.6.
Dr. Aftab Khan, do you hear me?
Yes, sir.
3.5 balloon.
One thing, when you putting the stent, placing the stent in the ostium, the RC catheter goes in the sucking effect in the inside the catheter. Right. How the fellows minimize this engaging mode the RC and just precise ostial placement of the stent?
Yeah, so that's what I was telling earlier. First thing is that to get your stent in, you need to make sure that your guide is coaxial. So your guide has to be absolutely coaxial for your stent to go in. If your guide is facing the other direction and you're trying to push your stent in, it will not go in.
10 by 8.
Coaxial. But once you've got your stent
8,
and you want to make sure that your guide does not go in and hit the ostium struts, what you can do is to de-rotate the stent a bit. So go counterclockwise or clockwise and get it away from the coaxial position. The second issue is to take another balloon or take another wire, and as I said, put it into this right sinus. So along with the stent that has been placed here, which is the wire which has gone into the native right coronary artery, you put another wire which goes into the right sinus. Now this wire will prevent a deep throating of your guide catheter. At the same time, it will make sure that your stent does not come back too much into the floating into the aortic ostium. So you put this wire into
open the tuhi. You can open the tuhi and can prevent the sucking of the catheter. When the pull the yes.
So that's important that always do it under fluoro. Never do this pulling back of the balloon without doing not fluoro, because that's the time when the guide usually gets nose dives in, and that can cause a dissection and cause problems.
Right, exactly.
Many times after doing the dilatation, you're waiting and then suddenly you start feeling
8, 10, 12.
falling, and that could be problematic.
14, 16, 18. Yes, cover stent. Rako, 380. Down. So I'm taking a small balloon, 3.58, because to give exact pressure on that, which is not, seems to me in the fluoro, it does not open up fully. So where the balloon was indented. So again.
So I think the fellows also need to understand that the balloon now that you're using is what we call as a non-compliant balloon. Unlike the balloon which is 18. There for pre-dilatation or inside the stent, which is usually a semi-compliant balloon. So non-compliant balloons do not grow as much. So when you go from a 3.5 balloon, when it goes to even 20 atmospheres, the balloon will go from 3.5 to around 3.6 or 3.65. It will not go to a 4 balloon. Whereas a semi-compliant balloon, if you take the same stent balloon and go high pressures, the balloon will grow, and a 3.5 balloon can cause a rupture.
14, 16,
so post-dilatation is usually with a non-compliant balloon rather than using a semi-compliant or a normal balloon.
So what I've done, just to open up that particular portion of the proximal lesion, which showed me fibrous, though I prepared with 3.5, 15 or 10 balloon properly before putting the stent, but even it seems it didn't open up. Minus, show me the stent size, stent deployment. Minus score. It na. Minus. So you can see the whole stent open up well, but the mid portion, there is some indentation, not much, maybe 10%. So plus, I've took a very small balloon, 3.58 millimeter. If we take a small balloon, we can make more force on the specific point. So if you take a big balloon, then what happened that the both sides open up well, but the mid portion become constricted. So I took a small balloon to give exact pressure on that side. And seems to me it's open up well, maybe 5% still there is residual. So I'll do an IVAS. IVAS ready, girl. So now it's post-stenting IVAS.
Did we have an angiogram picture after you've done the post dilatation, sir?
Sure.
If you could give some nitrates and dilate the artery, that look much better. Then.
Yeah. There could be perforation as well. I'm giving some nitro and then always give some nitro to give a good picture because sometimes there is a spasm. So I'm putting some nitro in. So I'm taking picture as Dr. Aftab said after doing the stenting because we need to check whether there is any perforation or dissection or not. Let's pray for the best. Seems good. Seems good.
Looking very good.
So I don't see any perforation yet,
Yes.
but there is some maybe 5% residual stenosis in the proximal portion yet, 5 to 10%. But I'll do IVAS, then let's see if it's.
Dr. Kaisar, I think there is some angulation there also in the lesion. So yes, whatever you are there is not that much maybe. I think it is well opposed there. So IVAS will tell the story.
Yeah.
I think there is some torque there. The
Dr. Aftab Khan, happy for the good, I think. Excellent is not good for the intervention. Dr. Aftab Khan?
No, wonderful. No, I think that's good. But again, at the same time, I think we have enough guidelines which tell us what is your optimal stent dilatation. So what is your criteria to decide that you've done optimally and not try and overdo things as Dr. Mohsin was saying, trying to achieve correct an oculostenotic reflex rather than correct a hemodynamically significant lesion. So I think the guidelines talk about making sure that
you know, Dr. Aftab.
Yes, sir.
Wait, stop.
You know, Dr. Aftab, that there is no IVAS in that case. So what you'll do actually, because for this lesion, you have already done enough.
Zoom IVAS answer. Zoom IVAS answer.
Later on, just you will have to like this. And you will have to keep it like this because more pressure with the 4 or something.
I definitely agree with you. Since your balloon, you have taken a 3.5 non-compliant balloon and you've gone to 20 atmospheres, I think one should be careful because all your branches are flowing. You've got a good distal flow. So this looks pretty well opposed, and I'll be really surprised if I find an artery that's not opposed well. But since you have an IVAS, it's worthwhile looking at it and seeing how it works.
Dr. Aftab has asked what is my take off for the IVAS, normal current. So usually if I achieve minimal stent luminal area, 90% of the distal normal reference vessel diameter, I'm happy. That's a guideline. That's the guideline. And though there is no cutoff value for the IVAS area, excepting left main, but it has been said that if you achieve an area of more than 5 or 5, the long-term outcome is very good. So for expansion, the area usually try to make it 5, around 5, but it's not any. There is a data there for like left main, which is 7 to 8. But the criteria is you have to make the minimal stent luminal area 90% of the distal normal reference vessel, at least 80%.
Yes, and I think what's also important.
We're doing the IVAS on. You can see the IVAS. So there is some plaque in the 3 to 6 o'clock position. So the vessel is.
So again, the criteria are not to land your stent onto an area which has a 50% plaque burden. So
this is 30%. 30%.
Yeah, so that's 30%.
So this is the stent. Right. There is no stent edge dissection. You can see.
IVAS.
So
IVAS. Please, okay, everything is fine. We see the IVAS nicely. Good evolution. We can congratulate the innovated hospital team. Kaisar,
the two criteria is that whether there is a well-apposed stent and whether the stent is well expanded. These are the two things we see post-stenting IVAS. And secondly, any complication like tissue prolapse or edge dissections. Why it is blue? green. Can you make it black and white? Yeah. So
Good
it's
apposition.
almost round shaped.
Yes.
Now we're coming to the proximal edge of the stent near the proximal, and now this is near the proximal edge. We've done with 3.5.
Stop.
Okay. So stents seem well opposed. So we'll see the minimal stent luminal area now. We're measuring it. It is 5.6. So more than 5. So stent area is good. Now we'll compare it with the distal normal reference vessel diameter. So while they're measuring the IVUS, I'm taking a last shot. So without pulling out the wire, because sometimes what Mohsin said that if the wire is in the branch, there could be some perforation. Though it's BMW wire, it's very rare, but we have to see. So you have to take long cine to see any perforation. Epicranial. So you can see the proximal portion is very well opposed. There is no dissection. Stent seems very well opposed, and there's no distal dissection as well.
It's important for the PD and PLV. So you should do the always epicranial. Both
we can see the small branches from the PD and PLV, but to me there seems to be no perforation. But it is rare with BMW wire, but it happens often with CTO wires. So with CTO wire, you should be very careful to keep it in the small branches, as Dr. Mohsin told. So that's it. My RCA done. Now I will go for the LAD.
We can finish today, Kaisar bhai, here.
Sure.
I think it's a for the fellows for the you do the complete. Thank you, Dr. Kaisar and his team. Excellent result. I think Dr. Khalid Mosif, his comments regarding this, I think good apposition of them.
Yeah. Thank you, Dr. Kaisar and your team for very nicely done case, and it was very well illustrative for our fellows. I would have to like to have a comment of you regarding the use of a single long stent and an overlapping stent. What is your choice, and what do you think that it's better to use a single stent which is long enough, or to overlap the stents?
Absolutely, you're right, Khalid bhai. We usually prefer to use single stent, but you know there's no stent over 48. So this is almost 62 or 3 in length. So I need to overlap with 2 stents. But if it's possible, I would definitely use single stent. But sometimes when there is a very calcified lesion, especially in the proximally, there is some calcification, it's difficult to take long stent. Then we can cover it with 2 stents, 1 stent, we take 2 small stents to track it to the lesion. But excepting those rare circumstances, we always take single long stent. And I just to finish for the fellows, can you show me the monitor, please? Monitor.
Yes, we are seeing nicely. We are seeing nicely. Yeah.
You can see the steps of successful PCI, Mohsin?
Yes. Seeing it nicely. Yes.
Yeah. So at the background. So fellows, while doing any PCI, because you should know the basic things, I always remember these 14 points. 14 points, 1, planning. And I tell all my fellows who works with me, they know it very well. Planning is the most important thing of PCI. Like in this case, whether the territory is viable or not, at Mishkat Bhai told whether we should go for PCI or not. If there's no chest pain, then according to Courage trial, PCI and medical therapy is almost the same. And observers said that if LAD is significant, then we should give the option the patient to cabbage. So planning and discussion before doing the PCI, which treatment is best for him, is very important. 1. Second is how to do the lesion. What wire I will take, what balloon I take, and what stent I will take. And if there is a problem, what is plan B, plan C? Especially if there's a complication, like, well, I will going for high pressure, ask my Cathlab technician, please bring the cover stent, 3, 18 or 19 here, because sometimes if it ruptures, then time is very less. So planning is very important. Second is monitoring. You have to see the hemodynamic monitoring, both pulse pressure, whether there's arrhythmia. Sometimes, as Mohsin told, that while I'm engaging the guiding catheter, there's pressure drop. So I have to pull the guide catheter back. So pressure and pulse monitoring, whether it's arrhythmia, you have to notice. Sometimes we are so engulfed doing the PCI, we forgot to see any VT, and patient we detect after 1 minute. This is very important. You should keep an eye, especially your assistant. Third is pharmacology, giving heparin, glycoprotein 2B3 inhibitors. These are adenosine, nitro for dilation of the lesion is very important. So keep this thing ready. Excess means, femoral radial excess. Usually we do cases 95% radial, but you should learn also doing femoral because CTOs and sometimes in the primary, or if there's a blockage in the radial artery, you have to go femoral as well. Second is engagement. How do you engage the guiding catheter? How do you engage the diagnostic catheter? And we have to very smooth. If you talk very roughly, it might dissect the ostia, as Dr. Aftab Khan said. Sometimes it pulled in the ostium. Angiography analysis is very important, and seeing a lesion in different views, especially after doing the PTCA, you must take, or for assessing a lesion, you must take 2 orthogonal view, because in one view you might not see the lesion properly, but in other 90-degree angulation you can see the lesion properly. And also post PCI evolution of the stent, you need 2 orthogonal view at least. Next, determine the target lesion. As Dr. Afzal said that whether this lesion to be treated, we should decide by IFR, or for taking rotablation, I can do IVAS to see the calcium. So to determine the target lesion and its severity is very important. Then wearing, what should be my workhorse wear? Like my workhorse is BMW wear, but sometimes if it's a very narrow lesion and 99% lesion, I take slippery wear like Whisper. And next is lesion preparation. Like in this case, I took very large balloon, 3 or 3.5 proximally, because the balloon is not giving away. So I wanted to optimize this first before putting the stent, because after putting stent, post-dilating, it sometimes in heart lesion become very tough. So you have to choose what lesion preparation will be made. If there is a calcified arc more than 270-degree, more than 5 millimeter, you have to do rota. And then stenting, which stent will take, how to take, like Khaled Bhai said, single stent is preferable, but sometimes you need to do double stent if length is high. And 11th is closure. We usually do by, compression method, the closure of the femoral excess, but we also use in our hospital the Abbott vascular device closer, which is per close, especially in CKD patients or obese patients. So you can take off the sheath just after the procedure, maybe 15 minutes. And of course, the physiology and imaging, which came today. Physiology means, the IFR, which is without hyperemia, FFR with hyperemia, and physiology is required for determining the significance of the lesion, whether we'll do it or not. That will be determined by IFR or FFR. And imaging is, how will I do it? Should I need a high pressure balloon? Should I need a cutting balloon? Should I need a rotablation? That will give me information, the imaging, that is IVAS or OCT. And last but not the least is hemodynamic support. You have to know that especially if the EF is low, you have to sometimes put IEP. Sometimes in our country it's not available, but Impel is a very good choice. And sometimes I put pulmonary venous catheter to see the pulmonary arterial pressure while doing a low EF case. So if it is very high, I put nitro and see. If it is still does not come down, then I do it in another day, not that day, especially with low EF case. And I also keep an excess for the IEP emergency if it's required. So that are the points you should remember, these 14 points. And it is told by the TCT, MD, or EuroPCR also. So if you keep this slide in your mind, then things become easier for you. Remember, you'll get away with 90% cases, 95% cases very easily. But in 5% cases, there is some unexpected problem which might cause death of your patient. But if you follow this chart, then you can save those patients, inshallah. Thank you so much. I end here. Any comments?
Thank you, Dr. Kaisar Khan, for the excellent, I think, workshop and your demonstration. I think everybody are delighted you will demonstrate and presentation. Dr. Aftab Khan, you're the last comments. Thank you for last 2.5 hours. Your busy schedule with us, Dr. Aftab Khan.
Yeah. It's been an honor being here and to watch Dr. Kaisar, his work here. And it's been always a pleasure to watch his work and to be with you all. Thank you for having me here. And Dr. Kaisar, it was a wonderful job. And I think, as you said, it was meticulous. It was safety first for the patient. And it requires a lot of teamwork. So congratulations to you and every member of your team who has made this procedure successful for the patient. And I'm sure the patient will get a good response from this therapy that he's had.
Thank you. Thank you. On the 26th, we'll be with Dr. Saidur Rahman in the Bardem Cathlabs, radial intervention. After that, on the 4th July, we come back in the United Hospital with the IVAS demonstration, Dr. Kaisar Nasrullah Khan. After that, Dr. Mirzamal sir, Professor Mirzamal sir, do you hear me, sir? Professor Mirzamaluddin sir, I think he will be on the after that. Okay. I am Mirzamaluddin sir. Sir, আপনি আছেন স্যার, আমি দেখছি স্যার। Mirzamal sir, please.
Am I unmute?
Sir, yes, we are hearing you, sir. On the,
are you hearing me?
Yes, sir. On the 26th, sir, we will be at the Bardem Hospital with Dr. Professor Saidur Rahman. Then 4th July, Dr. Kaisar Nasrullah Khan. After that, you will be in the NICVD with you, sir. Sir.
Okay, thank you.
Yes, sir. The last comment for the fellows, sir. Mirzamal sir. Any comments for the fellows?
Regarding comment for fellows, you are lucky. The fellows are lucky for observing or participating in such a nice case. Though it initially seemed to be an easy case for RCA, but finally it is shown that it is not so easy. And one thing you should remember always, that if your mind set up for doing a PCI is, oh no, it is a simple case, I shall do it very easily. Then when you are in any problem in that case, you will not be able to overcome. So you will always think any case that it is challenging or it is a very important work, not to take it as easy. If you will never do the PCI with thinking that it is very easy case. Always you should think it is difficult, but I shall have to overcome. Then it will be very easy for you for doing it. This is one sentence for you. Thank you all.
Thank you, sir. Thank you, sir. Chowdhury Meshkadam, sir.
Thank you. I've got two little comment. Number one, during preparation, if a patient do have CKD, hydration is very important.
Sure, sir. Thank you, sir.
Type of dye we are using. Number one. Number two, for the beginner in PCI, they should try to put the guide wire in the PDA rather than in the PLV, because PLV is the artery which commonly shows some perforation. So for the beginner, I think it is more important to try to keep wire in the PDA rather than in PLV.
Thank you, sir. Thank you. Thank you. Thank you, our faculties. Thank you so much, be with us. The participants in the Zoom connection, also in the Dhaka Medical College and Mohsin Medical College in the Cathlab. Thank you all. Now we are requesting our co-chairman, Dr. Khalid Mohsin, please conclude the session. Yes.
Thank you, Dr. Mohsin. It's your enthusiasm and the dynamic leadership of Professor Abdul Wadud Chowdhury. IPDI has come a long way and it is going to progress further. And I would like to thank Dr. Kaisar Nasrullah Khan, his team, and the authority of United Hospital to host this very august gathering. And Dr. Fatima is here. She also represents United Hospital. And thanks to Dr. Aftab Khan and Beximco Pharma for providing all the logistics for technically difficult situation. So I would like to thank them all, and Abbott Vascular also for providing technical support and and the other logistic support, and last but not the least, the fellows to whom this session is dedicated for attending this session with great patience and enthusiasm, and hopefully they will be with us in the future sessions to come, and the interventional cardiology will progress in this country to a great extent in future. With this, I would like to thank all the participants, and over to Dr. Mohsin to conclude.
Thank you, sir. Kaisar bhai, thank you so much. Kaisar bhai team, Tanvi, Dr. Motiur, all the Caltech staffs and nurse, technicians, also anesthetists here. Thank you, everybody, with great hospitality, with great lunch, also some refreshment here. Thank you, everybody. And Dr. Fateh Madam, thank you so much. And especially Dr. Aftab Khan, thank you so much. Assalamu alaikum. Beximco, you are doing from early morning, yesterday job to preparation of the labs, everything. Thank you, Beximco Pharma, and thank all the participants. Goodbye. Till you again, see you again on 26th and the Bardim Hospital. Thank you so much. Thank you.
Thank you all. Thank you.
Thank you.
We are honored. We are honored and humbled. 286. No, আমাকে হেপারিন দাও 2000 পিন দাও আমি এখানে ব্লাড